webinar on nurses caring for older persons. So, in this webinar, we are welcoming each and every person, those who have joined, and also I would like take this opportunity to welcome the speakers and the chairpersons for this webinar. So, first of all, the chairperson for this webinar is Dr. P.T. Sivakumar. Sir is the professor of the Department of Psychiatry, affiliated to he is affiliated to Geriatric Clinical and Services, Department of Psychiatry in Nimans, and working as a nodal officer in implementation of NALSA, that is Legal Services to Senior Citizens Scheme from 2016 in Karnataka. His area of interest is geriatric psychiatry and healthy aging. So he has published around 70 publications in various national and international journals. Welcome, sir, for this webinar.
Thanks.
Then I take the opportunity to welcome Dr. Alka Goel. Dr. Alka Goel is the Associate Professor in Faculty of Health Sciences, Department of Nursing and Health Promotion in Oslo Metropolitan University, Norway. She completed her graduation in nursing from Areke College of Nursing, New Delhi, and post-graduation in clinical mental health from Buskerud University College, Drammen, Norway, and PhD at University of Oslo. She has 34 years of professional experience in the field of nursing in various capacities as public health nurse, registered nurse, lecturer, and associate professor. She has published around 6 articles in international and 3 articles in Norwegian journal. She has also reviewed a book in Norwegian language. Her area of interest is working among patients with dementia. She has presented various papers and posters at the international conferences. She has been awarded a Leon Janus Research Prize in 2009 for a project on anxiety in people with dementia. Welcome, ma'am. Next, I'd like to welcome Dr. Leah McAdin. So she is the Senior Lecturer and Senior Fellow of UK Higher Education Academy. She has 33 years of professional experiences in the field of nursing in various capacities, and she is working as undergraduate module leader, UG Dementia Curriculum lead, PG module leader. She is also a leader for internationalization, Department of Nursing and Midwifery in UHI. She has guided many PhD and postgraduate nursing students. Her area of interest is diabetes services delivery, young people mental health and technology enabled dementia education and support. She has published around 50 journals and reviewed 2 books. She has numerous awards to her credits, to name some: Best Research Supervisor, HISA Award 2020, Churchill Fellowship 2019, Being Dementia Smart Enhanced Student Learning Award 2016, the Scottish Cubicle Award 2013, the Dr. Mary Sukulakshmi Immanuel PhD Award CMC Vellore, India in 2011. Welcome, ma'am, to this webinar. Now I would like the opportunity to welcome Dr. Sailakshmi Gandhi. Ma'am is the Additional Professor and Head of Department of Nursing, Consultant in Psychiatry Rehabilitation Services and Adult Psychiatry Unit. She has 35 years of professional experience in the field of nursing. She has worked in various capacities as tutor, assistant professor, associate professor, etc. Her areas of research interest are stress management, capacity building and manpower development, child and adolescent health, school mental health, suicide prevention, rehabilitation for persons with mental psychiatric illness. She has published more than 150 articles in national and international journals, authored 5 books and numerous book chapters. She is currently the principal investigator for 2 extramural funded and 2 non-funded multidisciplinary research projects. She has numerous awards to her credit. To mention a few: Florence Nightingale National Award by President of India for Best Nurse Educator in 2014, Dr. Radhakrishnan Gold Medal Award for Excellence in Individual Achievement and National Development by Global Economic Progress and Research Association 2012, the Florence Nightingale Award for the Best Nursing Tutor in Karnataka 2009, and so on. Welcome, ma'am, for this webinar. Now, I would request Dr. P.T. Sivakumar sir to take over the sessions.
Thanks, Pradeepa. At the outset, on behalf of the Geriatric Psychiatry team and the nurses, Department of Nursing team, and the entire Geriatric Clinic Services, which is the multidisciplinary team, I welcome all the panelists and also all the participants today. And we are going to have, I think, good kind of insights about various aspects about nurses' role in the caring of older persons. And it is important that, say, to note that we are in the time when the population aging is becoming a big issue, and rightly, the World Health Organization has declared 2020 to 30 as a decade of healthy aging. So, 1st October is the International Day for Older Persons, and this initiative of Decade of Healthy Aging has been launched formally. And India, being one of the largest countries to have the population of older adults, even though it is relatively young country, in terms of size of the population, India is one of the largest countries to have a large number of older adults. And the problem of population aging is kind of becoming more important now. The government as well as the various health professionals are taking note of it, and actually we are working towards gearing up in the next few decades to actually how to support, how to provide care for older adults. When it comes to elderly people, mental health is an important aspect, and any care of older adults with so much of physical health issues and mental health issues, nursing plays a crucial role. And I think even in developed countries globally, there is a shortage of human resources. In India, it is very, very primitive, I would say, in terms of specialization of nursing, psychiatric nursing in general, as well as you think of geriatric mental health nursing, it is relatively non-existent. So, NIMANS, the Geriatric Clinic Services team, is a multidisciplinary team, and we have been working towards this initiative to kind of develop human resources as an institute of national importance. One of the main mandates is to prepare the human resources need for the country, and possibly we can even look at the global needs, because still India is a relatively younger country, and the kind of human resources required, India will be one of the countries to meet the requests of the global needs also in many aspects. So I think it's a rightly timed event, and I think it's good that we are going to discuss a lot of things. We have very learned faculty and who's going to talk about various aspects of ranging from depression and anxiety in people with Alzheimer's disease to the dementia enhanced education to promote excellence, as well as the scope of geriatric mental health nursing. So I look forward to productive discussion, and this is just a beginning for us to engage in this area, and I think we will have many more such events to plan and to have to develop a continuous learning program. Possibly in the, I think the COVID times has emphasized the need for continued education, continued interventions, and development of services for elderly people who are the most vulnerable people among this COVID pandemic. I also want to note that this year is also a year of nurse and midwife. Rightly, World Health Organization has declared this 2020 as marking the 200th anniversary of Florence Nightingale, and I think all these things makes an important kind of occasion for us to start this initiative. So, with these few words, I would now invite Dr. Alka Goel to present on the role of nurses in addressing depression and anxiety in people with Alzheimer's disease. Yeah, over to you, Dr. Alka.
Thank you so much. Hello, everyone. First of all, I would like to thank Dr. Gandhi and Dr. Siva Kumar for giving me this, at NIMHANS, for giving me this opportunity to deliver a talk on the topic, role of nurses in addressing anxiety and depression in people with Alzheimer's disease. This topic is close to my heart, and the contents of this topic is mainly based on my own research and my clinical experiences, many years clinical experience in psychogeriatric departments. What has happened? Yes. The agenda of my today's talk is based mainly on 3 points. That is, why it is necessary to address anxiety and depression in people with Alzheimer's disease, and the role of nurses in addressing anxiety and depression in this population, and finally, the take-home message. I would start with one example from the clinic. Mr. Peter was in his late 70s. He was diagnosed with Alzheimer's disease for some years back, and lived with his wife at home. His wife noticed that he started wandering, and he was restless and had sleep disturbances. And in the daytime, he was following his wife everywhere like a shadow. And all this behavior in total made his wife very tired. She couldn't rest, she couldn't sleep, and was totally exhausted. And Peter was physically fit, but had moderate to severe dementia. And he was admitted to psychogeriatric unit for the further investigations of this behavior he had at home, and also to chalk out appropriate level of care. While he was admitted to the psychogeriatric ward, one of the nursing aides wrote in the patient's chart in the report that the patient had wandered most of the time during the shift, and although he seemed very tired, but he couldn't sit and he was restless. And he became somewhat calmer after the medicine, that was Alopam, which was given SOS. And it says further that in the report, the patient was not perceived anxious, and his restlessness was most probably due to dementia. And then we we assessed his behavior on the rating anxiety in dementia rating scale. We found that his score was 17 out of 54. This rate is the dementia-specific anxiety scale, and it has 18 variables or questions, and the total score is 54. A sum score of 11 illustrates a significant clinical anxiety. And this scale has been translated in Norwegian, and we have validated this scale for the people with dementia in nursing homes. And we found that the total sum score of 12 and above indicates clinical significant anxiety, and that is generalized anxiety symptoms. So the point is, elderly people with dementia or Alzheimer dementia have more diffuse or atypical symptoms when they have anxiety or depression than people without dementia or the younger population. I can see some of the red lines here in my presentation. I don't know what it is, so let it be. Anxiety and depression are two of the symptoms in a range of neuropsychiatric symptoms of dementia, which is also known as behavioral and psychological symptoms of dementia, or BPSD. And identifying anxiety and depression in people with dementia is very complicated, especially in late stages of dementia, as people may have overlapped the symptoms of anxiety, depression, and other physical disease. And people with dementia may have difficulties in expressing their feelings due to cognitive decline and speech problems. And moreover, nursing personnel's inadequate knowledge and awareness of expression of anxiety symptoms and of anxiety and depression symptoms can also be difficult. Lack of appropriate assessment scales for this population may add to this problem that anxiety and depression are overlooked or unidentified in people with dementia. The prevalence of anxiety in people with dementia. Anxiety as a disorder and symptom occur more frequently in people with dementia than people without dementia. The occurrence is up to 3 times higher incidences for anxiety symptoms in people with Alzheimer's disease than in healthy elderly is being observed. And the occurrence is 25 to 90% for anxiety symptoms and 5 to 38% for anxiety disorder, and that's mainly for generalized anxiety. And higher incidences among nursing home residents with dementia than people with dementia living at home. That means prevalence of anxiety is higher among nursing home residents with dementia than people with dementia living at home. The anxiety symptoms in elderly people. I've divided into 4 categories: cognitive, physical, emotional, and individual symptoms of anxiety in elderly people. Now we are talking mainly in elderly people. There are cognitive symptoms are worries related to health, own health, family members' health, worries related to economic problems, and these worries are difficult to control. And people may have difficulty in concentration, etc. Among physical symptoms of anxiety comes headaches, palpitations, stomach upset, and sleep disturbances are more common in elderly people than younger population. And emotional, some of the emotional symptoms of anxiety are restlessness, irritability, anger, and agitation. And there are certain individual symptoms of anxiety may also be there, like repetitive behavior or questions, as we see in many people with dementia. They keep on repeating same thing again and again. One thing, it can be the decline of memory, but I think it is also due to the anxiety that they keep on repeating. The thing is, things are complicated. This figure shows the presence of anxiety symptoms in people with dementia. The anxiety was assessed by RATE scale, rating anxiety in dementia, the Norwegian version. And the symptoms were observed at 2 time points, at baseline and at follow-up. And these are the symptoms which were found those in the participants, those who had clinical significant anxiety. And what we found is that the symptoms of irritability, muscles tension, anxiousness and frightened, and restlessness, these 4 symptoms were oftenly found in these people with clinical anxiety symptoms. And the symptom of worry about cognitive performance, interestingly, this symptom was reduced significantly during the 1-year follow-up period. So, and this is very interesting finding, because worries are the key symptom of generalized anxiety disorder. So this may explain one of the reasons that anxiety is under-identified among people with dementia, because they do not worry in the later stage of dementia. And moreover, it also shows that anxiety is represented in the behavior problem in moderate to a severe stage of dementia than the worries. So now we come to depression, or how to differentiate between depression or sorrow or sadness among elderly people. From our clinical experiences and evidence-based practice, it says that a person who mourns cries easily and can be distracted a while from the grief if others try to talk about other things. But a person with depression is not easy to distract and may seem more self-centered in conversations and focus on depressive topics or symptoms. And hope in people with depression is almost difficult to find than the patient with dementia. But for some people, a grief, sorrow can be very heavy to bear and difficult to deal with, and it may develop into a depression state. So the point is that we health personnel should look for to what extent do the symptoms affect a person's ability to function in daily life activities and quality of life over time? That is important. The prevalence of depression in people with dementia. I say people with dementia, people with Alzheimer's disease interchangeably, because the most majority of people with dementia, they have Alzheimer's dementia. The depression both as symptom and as disorder is common in people with dementia than those without dementia. And the occurrence is between 8 to 77% for depression symptoms in nursing homes, and up to 27% for depressive disorders, and up to 21% for clinically significant depression in people with dementia in nursing homes. And in this study, the depression was assessed with Cornell scale of depression with the sum score 8 and above. I'll come back to this scale, Cornell scale. And we know that depression is higher in people with vascular dementia and Parkinson dementia than in people with Alzheimer's disease. Now, the symptoms of depression in elderly people with dementia is that sadness and discouragement is less pronounced, possibly absent in elderly people with dementia. As I mentioned, that people with dementia have atypical or diffuse symptoms of anxiety and depression. So this is what I'm just repeating, that lack of joy and despair is more pronounced in elderly people, and physical symptoms like stomach upset, sleep disturbances, and that they have that there's something is going wrong with their body is more expressed in elderly people with dementia than younger people. And there is a lack of interest.
A second.
Hello?
Dr. Alka?
Yes?
Our IT cell here is telling that maybe multiple tabs are opened at your end, and that's why those lines are coming. Can you please keep the other appliance devices switched off? Only the one which you're using for the presentation open, please.
Okay. I don't know how to...
Any other devices which are opened?
But Salishmi, I think we may proceed. I think it is not interfering much. I think right now it will distract others. We can go ahead, I think.
Okay. That's what I was wondering. I don't know what has happened suddenly.
I think there are multiple possibilities. Let us, if we get into it, it will become delay the things.
Yes.
So,
Okay. Okay.
Going on, we can continue.
And emotional incontinence, that is uncontrolled episodes of crying and or language may occur, laughing may occur in these people with dementia. And one of the study in Norway, they found that irritability is the most of the prevalent symptoms of depression in elderly people with or without dementia. And anxiety is more pronounced in elderly with depression. And restlessness is also more pronounced in people with Alzheimer's disease. And there is also sleep disturbance, that people may sleep too much or not enough. And there is a reduced appetite, weight loss may occur, and the delusion, self-blame. The delusion is a character of that, the people, that there is a ruination of delusion that something is wrong, something is going to happen very badly. They may have economic problems, like that, delusions they have. That's very sad type of delusion they have, not happy type of. And they self-blame themselves. And then there are suicidal thoughts that is less expressed in elderly, but suicide rate is higher in elderly people, at least in Europe. So how to differentiate between depression versus dementia? In depression, there is a relatively short medical history, and the language is intact in depression, but reduced in dementia. Orientation ability is also intact in depression, but reduced in dementia. And the thinking process is intact in mild and moderate depression, but it is reduced in dementia. Abstract thinking is intact and reduced in dementia. Insight in cognitive decline is highly present in depression, but it may not be present in people with dementia. And hope, that is also very important, is almost absent or reduced in people with depression, and it may not be the case in people with only dementia. And when you talk to the people with depression, the clinician feels a sort of sadness. And this is not the case in people with dementia. And finally, the cognitive changes, they get better after treatment with depression, but in dementia, it deteriorates with the time. So this is the picture shows the association between anxiety and depression in people with dementia. Here it shows that 50% of the people who had anxiety had depression in addition, but 80% of the people who had depression had anxiety in addition. So we are talking about comorbidity of anxiety and depression. And this relationship was almost stable in a period of one year with slight changes. I see I have only 5 minutes. The impact of anxiety and depression in people with Alzheimer's disease is that in line with other general population, anxiety and depression often co-occur in this population also. Anxiety and depression both has a single condition, and as comorbidity has many negative impacts in people with dementia, such as increased dependency, significant burden on patients and caregivers, and an increased number of behavioral symptoms. And most important, the comorbid anxiety and depression lead to delayed remission and reduced quality of life. This picture shows that the people who had both anxiety and depression has the worst quality of life than the people with only anxiety or only depression or with none of these conditions. Now, the contributing factors to anxiety and depression are many. That is an interplay of biological and psychosocial factors that may contribute to anxiety and depression. Like there are certain biological fixed factors which are difficult to alter, difficult to change, like age is a risk factor which we cannot do anything with that, and genetic vulnerabilities, and the structural and functional changes in the brain, also physical and mental diseases, vision and hearing. The number is a lot, but there are tractable factors, biological tractable factors which we can change with the implementation, with the interventions, like we can control infection, delirium, pain, some of the neuropsychiatric symptoms, side effects of antipsychotics, etc. And like that, there are psychosocial fixed factors which are difficult to do something with, but there are psychological tractable factors which we can alter with the interventions, like the environment, how to interact with the people, and like Kitwood had said, malignant social psychology of the dementia. And Cohen also has said that with the relation interaction, anxiety-like conditions may occur. And the role of nurses in addressing anxiety is that it is also a comprehensive assessment, and it's a systematic assessment of person, like knowledge of person's medical history, adequate management of infection and pains, critical review of medications, provision of sensory aids like that, and then psychosocial interventions like you can have the physical activities, assessment of anxiety and depression is very important, which I'm coming to this topic, and cognitive stimulation therapy, yoga, which I have seen at NIMHANS, music therapy, reminiscence. The point is that we should know the person's likes and dislikes and the person's resources to manage a plan for treatment of anxiety and depression. And here I will present some assessment tools to chart anxiety and depression so that we can evaluate the treatment is going in right direction or not. I will present the rating anxiety and dementia scale, which has 54, total score is 54. Now this is happening, I'm not doing anything.
Somebody else has got access.
I'm not doing anything with this.
In Zoom, there is an option where you have to disable.
I think this is somebody else is doing this. Anyway, and geriatric anxiety inventory and Cornell scale for depression that has 38 highest number, and the scale. Yes, these are the three I will advocate for for the nurses to use this assessment scale to assess anxiety and depression in people with dementia, because it is very, very important. And my take-home message is, if that anxiety and depression are highly prevalent among people with dementia, and it has negative impacts such as increased behavioral changes and reduced quality of life. And comorbid anxiety and depression in people with Alzheimer's disease lead to delayed remission than people with anxiety or depression with only anxiety or only depression. This is a very important message, that anxiety, depression often co-occurs and they lead to delayed remission. That's why it is important to assess the severity of the symptoms, and so that we can plan the care for the person. And it is important among nursing home personnel to increase awareness of and skills in identify anxiety and depression using validated dementia-specific anxiety and depression scales, and ensuring adequate management to enhance quality of life of people with dementia, Alzheimer's disease. This is the reference list, and this is my thesis. If somebody is interested, I can email. So I will thank you, all of you, for the attention. Thank you.
Yeah. Thanks, Dr. Alka. I think you have finished well within time, and it was a very informative talk, and I appreciate your, because you have actually spoken about from your both practical experience as well as your research, and as you have highlighted, this is something like very, very important topic. And people with dementia, many times, once dementia, both the family members and the clinicians can have a very nihilistic attitude and say that, okay, one may not actually look at something which is treatable. So they also may have comorbidities, both physical as well as psychiatric comorbidities, which may actually make the cognitive impairment more severe than what it is. So it is a very
true.
Important treatable aspect. Say there are patients where we have seen who have been treated as patients with dementia for years, and then once we have actually admitted and evaluated, by recognizing depression and treating it adequately, the level of cognitive impairment also improves to some extent, where you have to rethink whether the person has dementia or not. Somebody who might have thought as moderate depression, moderate dementia, might look like a mild or a mild cognitive impairment. So that level of improvement in quality of life can happen. So it is something like which everybody needs to recognize, particularly in the context of residential care. I think people who get into residential care, many times it is seen as something like an end point of time. There are doctors who might have told, okay, this person may not actually live longer, you may not be able to do anything just to take care. And to prove their predictions wrong, people have recovered after the stabilization of their physical health, and a good care, good nursing care can actually give a good quality of life. And once we are able to recognize, if the nurses are able to recognize these treatable problems, I think it can do a very big kind of contributing, it can contribute to enhancement of the quality of life. So maybe I think we will take up the discussion in the end with all the speakers once they finish, for want of time. So I would again thank Dr. Alka for the very lucid presentation. I'm sorry for the disturbances that is happening in the slides. I think these are some things like one of the participants, they might have enabled an access where they, without realizing, they may be scribbling something. It is more kind of unintentional, we feel. I think it also added color to your presentation. So we can become inclusive and we can become tolerant. And when such things happen, whether it is children or elderly, we don't get disturbed. So we can go on with it.
I think there is one name was coming there. I wasn't touching anything. It was just coming and going, coming and going. Yes. Anyway.
You should not be blamed for it. Okay, it is a technical glitch. I think people are learning
Yes.
with using these platforms. So we will learn. I think this is a problem which has been actually very well recognized. So I think our technical team also will learn as to how to manage it. Okay. So
Yes.
I think we will move on to the next presentation. It is about igniting the spark, dementia enhanced education to promote excellence. I think we cannot get a better person than Dr. Leah, who has worked extensively in this area and from UK. So she has kind of been working in the area of dementia. And over to you, Dr. Leah. I think it's a very important thing as to education related to dementia. So we are keen to listen from you and then see as to how to take it forward. Over to you, Dr. Leah.
Thank you, Dr. Shivakumar, Dr. Gandhi, and Dr. Goyal. It's good to be here and very fitting, I think, to talk about this educational initiative, particularly this week. My slides aren't loading up. Okay, there they are.
Slides are there. Yeah.
Yes. Okay. So yes, thank you very much for giving me this opportunity to share some of my experiences with developing the dementia nursing education programs, which I've been involved with from 2013. I've called it Igniting the Spark because I'm very passionate about this area of my work, which I've kind of been drawn to seeing the need around us in terms of the number of people, not just within the UK, but globally being affected by this illness. My slides don't seem to be moving. Okay.
Are you able to move the slides? Yeah.
Yes, okay. So greetings from University of the Highlands and Islands, where I work, and we are based in Inverness. For those of you who don't know where Inverness is, it's in the north of Scotland, so it's a very beautiful part of the world that we live in. So that's a picture of the department. Of course, from March 16th, I've been working from home, but we work in a very beautiful Center for Health Science that lends itself very well for collaborative work. And those are some pictures of our landscape. I just thought I'll give you a taste of the beautiful place that we live in and work. Okay, to set the context, where did this initiative come from? When I moved to Scotland from CMC Vellore in 2011 and started working at the University of Stirling in 2012, my first responsibility was to develop a postgraduate dementia module within an MSc in health and well-being of the older person. And I wasn't familiar with dementia to the scale that I have become familiar with and passionate about. So that was really the beginnings of my interest in this area of work. What got me going was looking at the scale of dementia and the global projections. So we may be familiar with this, but by 2050, there's a projection of 152 million people living with dementia, and that's a 204% increase. And if dementia was to be considered as an economy, it's really shocking to see that it'll be the 18th largest economy in the world. So that's the scale of the problem in front of us. And having been trained in Vellore, my heart is always in practice, even though I'm not directly involved with practice. So I thought, there is something that surely we should be able to do to address this problem, at least with developing the future nursing workforce. So within the UK, by 2050, the projections are that the increase will be to 2 million people. And in Scotland, we currently have over 90,000 people living with dementia, and about 3,200 of those people are below the age of 65. Now, this is something important to bear in our minds because with multimorbidity, I think increasingly people are developing cognitive impairments and various types of dementia as well. So I would like to emphasize the fact that dementia, at least we don't see dementia as an exclusive psychiatric problem anymore. it's a neurodegenerative problem and it could happen to any older person. So we're trying to kind of destigmatize this as a mental health issue. And like what Alka was saying earlier, that often depression and dementia and delirium can coexist in people. So it's even more important to recognize this as a neurodegenerative problem. So the solution within the UK was that each of the 4 nations came with their own training framework for workforce education and training. But for the purpose of today, I will be concentrating on the Scottish framework, which is called the Promoting Excellence Framework. I won't spend a lot of time on this slide. I'm sure you're familiar with the evidence around the gaps and the need for dementia education that's increasingly being cited across various health disciplines and social care disciplines. So the way forward, perhaps, in my mind, right from 2013, was that we probably should be investing in education and training, all frontline staff. And this needs to be at the core of all the national dementia policies and standards that any country set for the future. So Scotland's dementia journey has been a very interesting one. Over the last 13 years, we've come a long way as a nation. And I think the right decision was made when dementia was made a national priority in 2007. So we've had 3 national strategies so far, and a national training framework was jointly developed by NHS Education for Scotland, that is for the healthcare sector, and SSC, which is Scottish Social Services Council, for the social care sector. So the government commissioned these 2 large educational bodies to come up with a framework, and that's the Promoting Excellence Framework. So within the second national strategy, you would see that there was an emphasis to develop the workforce against this framework. And this is the deep curriculum. I'll talk about it in a little while. So that's where this thing fits. Now, again, for those of you who are not familiar with the context of healthcare within the UK, because we have the National Health Service, all our programs that we design and deliver has to be in line with the policies as well. So that works really well. So it's usually underpinned by policies and strategies. The second policy that I would like to highlight is the standards for dementia care in Scotland in 2011. There was a Charter of Rights that was developed, and the Charter of Rights, interestingly, was developed by people living with dementia. We have the Scottish Dementia Working Group, and the membership consists of people living with dementia. So there are multiple rights that they identified, and one of the rights was that they had the right to have people who are well supported and educated about dementia. So again, the curriculum kind of addresses that. So that's the Promoting Excellence Framework. There are 4 levels. We won't go into the details, but basically the level is decided depending on the frequency and the intensity of contact the staff need to have with people living with dementia while they care for them. So it moves from informed to the expertise level. And the program that I've developed will help our students to exit at the enhanced level, which is one below the top. So in 2014, we did a survey with our semester 1 students. It's a 3-year BSc nursing program, unlike India where we have 4 years. So we have 6 semesters across the 3 years. And following the first placement, one of the surveys I did was to ask students how many of them had come across somebody with dementia that they had to look after within their first semester. 90% of the students had someone to look after with dementia. Now we have this myth that all these people living with dementia are in care home or residential care settings. And if you look at the placement, most of them were in the acute general hospital. And again, this reinforces the point that this is not just for people living in care homes and residential care. It's not a psychiatric illness. It is, like any other medical problem. In the UK, 1 in 4 hospital beds are occupied by somebody over the age of 65 due to the demographic transition, which Dr. Shivakumar alluded to at the beginning. And 25% of these people have some form of dementia or cognitive impairment. So that's really huge. And that is why I took it upon myself that nurses of the future needed to be trained and educated on this important subject. More recently, we did a survey that was in 2019. Again, 98.9% of the students had cared for somebody with dementia over the 3 years of their placements on the BSc nursing program. And most students had more than 15 people at least they have looked after over the 3 years. So that's the context. I hope that gives you a bit of an idea as to why this was so important. So I thought we were missing a trick in undergraduate nurse education and started looking at how can we address this gap. We can't particularly do anything with the existing staff because that was not within my job portfolio. So I thought, okay, we have 300 students going through our doors every year, and maybe we can start with them and start building capacity and capability for the future. The other reason I did this was, we know people working with older people is not an attractive option for any healthcare professional, and that includes nurses. But we have a problem in front of us. So how do we fix this? And I thought maybe people don't prefer to work within the specialty because they don't have the knowledge and the skills. So it was important to address that need. So the dementia curriculum that I developed in 2014 was called Being Dementia Smart. We won't talk about that just now because we don't have a lot of time. But I'll talk about DEEP, which is an acronym for Dementia Enhanced Education to Promote Excellence. I wanted the level within the framework and the title of the framework captured in the program as well, and hence the name DEEP. So this is basically built on two premises. One is the Promoting Excellence framework itself. And the second thing I felt it was important for students to follow the stages of the dementia journey when the curriculum was being delivered. So they appreciate that this is a progressive illness and they're able to understand what the specific issues are at different points of the illness. So I came across Barbara's story, and I would really encourage people to have a look at Barbara's story. This is a fictional story that was created by guys in St. Thomas's in London to enhance dementia awareness for their staff development. So that has really worked well. There are 6 episodes within Barbara's story, and I have mapped the episodes to each of the taught content within each semester. So students actually follow Barbara right through the DEEP curriculum. So they kind of, it's almost like immersive learning, following this thread with Barbara. And more importantly, I think because it's such an emotive story, students are internalizing a lot of the learning that they have during the program. So that's the student's journey, right from prevention of dementia up until end of life care. Everything that they need to know is covered within the curriculum. We won't go into the details of this, but basically I've used the theory of constructivism to design this program, building cognitive bridges, incremental learning, educator being a facilitator, and so on. So students enter the program in semester 1 at the informed level, the basic level of the Promoting Excellence framework, and move through to the enhanced level when they exit. Another reason I did this was to make sure if somebody drops out of the nursing program, usually they go into the care home sector, to carry on their jobs. So I thought it would be helpful for them to have some form of dementia qualification if they chose to drop out of nursing. So that's what the curriculum looks like right from semester 1 through to semester 6. So keeping well, prevention and diagnosis of dementia to dying well with dementia. I'm sure you'll have a copy of the slides. I won't have the time to go through all of the curriculum components, but we do train and certify all students as dementia friends in the first semester. The program is delivered using what we call a multi-agency approach. Scotland has 1 dementia nurse consultant in each of the health boards. So we get the dementia nurse consultant coming and teaching the students. We have Alzheimer Scotland staff like link workers and advisors for dementia coming and teaching the students. People living with dementia coming and teaching the students in semester 1 to explain what it is like to live with this condition, family carers of people. So it's quite an interesting methodology that is adopted to deliver various components of the training. And students are expected to maintain a portfolio of evidence of engagement with the program. It's a compulsory component of the program. And at the end, when the portfolio is completed, students get certified. The other important thing that we have included in this curriculum is sensory impairments in older adults, because you will again see in evidence that sensory impairments coexist with cognitive impairments, particularly hearing impairments. And there's a whole lot of importance around that, because somebody with a hearing impairment, if it's not assessed well, could be misinterpreted as someone having cognitive impairment. So it's really important that students learn how to recognize these in older adults. So, it's a simulation that I have developed. Maybe this is for another day, but there is some published work on this as well, which is available in the British Journal of Nursing. Students just love this simulation. The important thing I've realized both with DEEP and the simulation is that even though it's very dementia focused, there's a lot of transferable learning in terms of skills and values that they can carry with them for their nursing practice across any practice area that they choose to work. So that has been an added bonus. So a range of teaching and learning methods are used, as you can see from this slide, and I think part of it I have explained. One of the key things we use is reflective learning. So when students watch Barbara's story in each semester, there's a facilitated discussion in the class, and they will have to do their own reflective piece. It's a short reflective piece on selected components of that episode. And then I encourage them to link it to the Nursing and Midwifery Council Code of Practice, so that they are underpinning all their learning within the Code of Practice as well. And in 2017, when I moved to University of the Highlands and Islands, I thought it's time to change. We probably need to have a curriculum that is suitable for blended approach because of sustainability issues. It's very person dependent, and I've been kind of driving this whole initiative. So I thought maybe we need to look at using technology. Whoever thought COVID was going to come around in 2020, and this has worked well, and we've used the ARCS model of motivation to design the blended resources. So I worked with the educational technologists and instructional designers at the university, and we came up with this brilliant idea of developing semester-specific workbooks. This has worked really well during COVID time, because our first cohort that graduated in August of this year were able to complete the program without any interruptions. So if it was all face-to-face teaching, I think we may not have been able to be successful with the program. I can't open this link because it'll take me out of this presentation, but please feel free to use the link and explore the workbooks. But that's what the workbook looks like. So it's very standard in terms of its format. Every semester has one workbook. So the students get 1 day of teaching per semester. So it's not a lot of face-to-face teaching, but all the taught component is covered. And then they've got this workbook with lots of related interactive activities. And that's really important for adult learners, that we don't spoon feed them everything and kind of encourage rote learning. But this is given the flexibility for students to learn at their pace. All the workbooks are made available for them throughout the 3 years of the program, and also to complete the portfolio requirements. So that's what the portfolio looks like. For each semester, the evidence is laid out. So the students will complete, and the personal academic tutor will be signing off these requirements. Now, what this has done is it has raised the profile of dementia and dementia education within the department. Even though I'm leading it, all my colleagues are part of it because they are looking after their own students' portfolio of evidence. They're familiar with what the students are learning. In fact, I think they're quite excited about the progress the students are making on this program, because students often share experiences of how they have used their learning in practice. So that's been another huge benefit. So I did get some feedback, formal feedback with a survey with the first cohort at the new university, having used this blended approach. And as you can read from the slides, and the next slide as well, students have been extremely positive, and I often tell them, I've ignited the spark, but you're the agents of change who are going to make this difference for the next generation of nurses and all the future generation. So it's a bit like in the reverse order. They are even kind of sharing their knowledge and experience with the staff who are mentoring them. And now there is a request from the staff to have, some kind of dementia training because the students know more than the staff. So I really think we have ignited the spark for this. The added value has been that students' employability is also gone up because everyone is looking for somebody with this dementia knowledge and skill set to employ them because of the reasons we've discussed earlier. Importantly, I think the program has helped the students to see the person behind dementia and not the dementia label. So I encourage students to look at an assets-based approach and not concentrate on the losses that the person with dementia has experienced, but to look at the remaining abilities and support them to live as independently as they can for as long as they can, because we know that if we encourage people to do things for themselves safely, then the cognitive decline is also slower. So the program, Being Dementia Smart, the first one has had some national awards and recognition so far. And I just want to say at this time that not having known anything about dementia when moving to Scotland, this was a burden and that was laid on my heart. And I would just like to say that God has been the architect and I've just been the tool responding to a need. And I think it's been just blessed and multiplied. So we've also had some, winners with the program. This is an important one. DEEP has been endorsed as exactly the type of innovation that is needed for future healthcare professionals. And this is coming from the Chief Executive of Alzheimer Scotland, which is our national third sector. And they work very closely with the Scottish government, driving all the policy and the changes. So that's been very encouraging. We managed to add 2 value-added initiatives working with Alzheimer Scotland. I've managed to get a very small travel bursary for the students to encourage them to apply for this competitively, and up to 4 students each year will be funded for a week to go anywhere in the UK in their second year to learn dementia best practice. Now this does 2 things. It's like a 2-way street. I was the recipient of the Churchill Fellowship last year, and I know how much travel and knowledge exchange can enhance, not just learning, but also transfer of ideas, something like what we're doing now. So I thought it's good for students to showcase what they have learned on the program, but also learn other best practices and bring it to the program. And because people living with dementia and their family carers and Alzheimer Scotland staff teach so faithfully every year for the students, I felt it was important that students gave something back. So we initiated a fundraising event by the students, supported by staff, to raise funds for the local Dementia Resource Center from last year. We couldn't do it this year. Hopefully we'll carry on. And students managed to raise £800 at the first fundraising event. So they went to the resource center, presented the check, had a tour of the facilities, and that relationship is being strengthened. So I'm almost at the end of my presentation. There's been a systematic review in 2017 by Sir et al. Looking at effective dementia education, what really works. And you would see that they have highlighted a few things from this extensive literature review that they've undertaken. And I'm pleased to say that DEEP addresses all these recommendations, perhaps even more than these recommendations. So in summary, I'm just pleased to report that with Being Dementia Smart, introduced in 2014 as part of the nursing curriculum, without taking anything out but seamlessly fitting in within the 3-year program, we have trained 1,000 nursing graduates at the enhanced level of a national training framework. And with DEEP, we will be having between 125 to 150 graduates each year, starting from August 2020, who have just passed out. So I've shared this idea with a number of academics and practitioners all over the world. I try not to miss an opportunity because I really think this is the way forward to kind of, destigmatize the subject, give quality of life to these people, and also become, instruments of change for dementia care practice, because we need to change that culture of practice, not just for dementia, but I think care of the older adult, because these are people who've invested in society, who've invested in all our lives, and I think it's really important we give something back to improve their care. So those are just some pictures. I was privileged to go to Johns Hopkins and UPenn as part of my Churchill Fellowship last year. The second phase couldn't progress, and I was supposed to be in NIMHANS this year in March, but because of COVID, we couldn't. I'm glad we're doing it this way. So those are some pictures. And what next? I'm just trying to kind of share this idea and look for partnership working towards developing a global model of dementia nurse education, because this is a global issue. The context and the culture and policies may be different, but definitely there can be a skeleton of the curriculum that is really uniform across the world. I'm also looking for funding to formally evaluate this approach to dementia education and pre-registration nurse education, so that we can establish evidence and probably move in that direction. So that's the end of my presentation. So thank you very much for this opportunity, and it's really good to be here speaking to all of you. Thank you.
Thank you very much, Dr. Leah. It was a very wonderful presentation and it was very insightful. I think you have covered many important aspects, ranging from say stigma to having some kind of a innovative educational model, and how say dementia is not something which is important in only nursing care or residential care centers. You can see in the hospital setting or in the community setting, it can touch everybody's life. In some way or other, we will see that I think Europe has already seen that, Europe and UK. I think in our settings, it is happening every day in and day out. This is something increasing in terms of the population of elderly or population of older adults. So it is inevitable that some form of cognitive impairment one has to face. One has to see in their family life or personal life or in their professional life. They may be dealing with an elderly person for any other thing not connected to the mental health setting. Still they might have to, this knowledge will be very useful. So how do we integrate this, say, dementia education into the nursing care? It may be existent as a small component, but as I said, having a student-led learning or a 360-degree learning or evolving different pedagogical methods, which can give a more deeper kind of learning for them, and which can kind of give skill building, because every specialty is important. I think it's becoming a challenge in terms of accommodating the time in the training. So we need a lot of innovations. And in this context, in India, a new national education policy has been launched, and we are looking at different kinds of methods. I think one of the components is about continuous learning and continuous assessments, and these are things which I think in our own training programs, which Dr. Sailakshmi would be talking about it now, we will definitely like to incorporate these elements and see as to how we can take it to the UG teaching. So what we are right now doing in NIMHANS is more of a postgraduate teaching, but there is a scope even in UG teaching also. So I think we will come back to the questions. I think we are running short of time, but I think it was a very insightful presentation. That's why I didn't stop you in between. I think many of the participants today are students, so they may be interested to know more about these things. Since you're sharing the slides, I guess people will be benefiting and then knowing more about these aspects. Now I would I again thank Dr. Leah, and we'll move on to the next presentation. The discussion, we will take it together. And Dr. Sailakshmi Gandhi is a familiar face. I think most of the participants would be they would know her very well. And she's one of our team members in the geriatric clinic services. So I invite Dr. Sailakshmi Gandhi to present about the scope for geriatric mental health nursing in India. Over to you, Dr. Sailakshmi.
Yes, sir. Thank you, Dr. Shivkumar. Just 1 second, I'll start sharing the slides. Yeah. Are the slides visible?
Yes, yes, yes. You can make it a slideshow.
Yeah.
You can just enlarge it. F5, you can press F5 also.
Yeah. Okay, thank you, Dr. Shivkumar, for that, for introducing the topic. And I must say that both Alka and Leah have made my job quite easy because my presentation is on scope for geriatric mental health nursing in India. And like you said, I think there are many students and teaching faculty also logged in here. And I think this is the correct time to show how important it is that we start courses in this area, considering that, like you rightly pointed out, 2020 to 2030 is the decade of healthy aging, and WHO has declared 2020 as the year of nurses. So I think it's very apt that all nursing professionals join together and start these courses related to geriatric nursing or geriatric mental health nursing. Uh, I'll be talking a little about the lifespan, mental health issues in older persons, how can nurses help, and about the fellowship in the geriatric mental health nursing course that we are going to start at NIMHANS. So we all know that life expectancy around the world has been increasing steadily. And as per the World Health Organization's declaration in 2016, the life expectancy was 72 years. We are not far behind in India. It is 70 years, 70.4 years to be exact, for females 71.8 and males 69.2. We also know that the number of persons aged 65 or above is projected to more than double in Eastern, Southeastern Asia, as well as other parts, Latin America, Caribbean, Northern Africa, Western, Central, and Southern Asia. And according to the World Population Prospects 2019, by 2050, 1 in 6 people in the world will be over the age of 65. There were 703 million persons aged 65 years or over in the world in 2019. The number of older persons is projected to double to 1.5 billion in 2050. So while we are very happy that lifespan is increasing, what are the causes for this increase globally? There are many reasons, according to literature: decrease in cause of specific death, improvement in nutritional status in the elderly, decrease in nutritional deficiency, a very wide array of healthcare innovations, treatment of established diseases, and also risk factor reduction in the area of smoking, high blood pressure and cholesterol, improvement in management of cancer, and beyond this, better medical treatment, immunization, control of tuberculosis, malaria, improved sanitation, sewage treatment, clean drinking water. So these are various causes which have led to increase in lifespan. I think it's important that we now know that we have a very large population of older persons, not only in the world, but also in India. Let's look at what are the mental health issues which our older persons could be facing. So we see here that depression tops the list, affects 7% of the world's older population, followed by dementia 5%, anxiety disorders affect 3.8%, and substance use problems affect almost 1%, while around a quarter of deaths are from self-harm. So in India, the mental health issues among the older persons, we find substance use disorders 27.5%, followed by 3.5% of mood disorders, neurotic stress-related disorders, and lastly, schizophrenia and psychotic disorders. The incidence of dementia, if we see world around, 50 million people at least have dementia, and every year there are at least 10 million new cases every year. Of this, Alzheimer's disease is the most common form and may contribute to 60 to 70% of cases. So what's happening in India here, if you see way back in 2005, the figure was 3.1 million, and now in 2020, it is 5.3 million, projected to be nearly 14.3 million by the time we reach the year 2050. So this is from ARDSI in 2018, and this is quite a shocking fact. And I think it makes us understand even more the reason why the older people need help from health professionals, especially mental health professionals. So the cause of mental health issues in the older persons are again many, varied, starting from loss in capacities, a decline in functional ability, reduced mobility, chronic pain, chronic health problems, bereavement, drop in socioeconomic status with retirement, urbanization, westernization, change in social structure, maladaptive emotional responses, loss of physical and mental capacities, loss of loved ones, and once they retire, loss of authority, loss of importance, difficulty in accepting and adaptation to change, physical illness, and also what we call as the emptiness syndrome, where their offsprings, their children have grown up, have moved on for either work or got married, and so now the older persons are alone, and because of this loneliness they might go into depression. So these are various problems which can affect older persons. And what can we as nursing professionals do about this? There are many geriatric courses in countries abroad, in the USA, in the UK, in Canada. We have just heard Alka speaking about her PhD area of work in area of dementia. We have heard Leah speaking about the curriculum which she has developed for people with dementia, and nearly 1,000 students have gone out of that course. In India, geriatric nursing course is offered by CMC Vellore, a one-year post-basic diploma course. And I'm not really sure whether any other institute in the country offers this course. I have only heard that CMC Vellore is offering it. And people may correct me later in the chat box if it is there anywhere else. IGNO also offers a 6-month certificate course in geriatric care. Unfortunately, there are no courses in geriatric mental health nursing in India. Now, having listened to me so far, I think that we will all agree that it's very important and that a course be started in this area, especially considering that this year is the year of the nurse and we are also starting the decade of healthy aging. So it is, I'm really happy to say that NIMHANS, both Department of Psychiatry, the Geriatric Services, and the Department of Nursing in collaboration, will be starting a one-year fellowship course in geriatric mental health nursing from July 2021. And this course would provide training related to provision of nursing care for elderly with mental health problems. The training opportunities are very vast. They are through extramural collaboration. We have a 10-bedded geriatric ward, residential and daycare facilities for dementia, and the geriatric clinic, which runs thrice a week for elderly above 60 years of age with various neuropsychiatric issues like Alzheimer's, dementia, depression. You can see a picture here of the geriatric team. You can see Dr. P.D. Shivkumar, Dr. Matthew, and the rest of the team over there. There's also a Dementia Center for Excellency, which is going to come up shortly. Dr. P.T. Shivkumar has done a lot of work and got a grant, and this center is going to come up shortly at our Sakalwara Community Mental Health Center. That's part of NIMHANS. There are also various fellowship courses in geriatric mental health, including the geriatric mental health nursing. And we were looking forward to Dr. Leah McDean's visit in March. She had received the Churchill Fellowship to spread word about her curriculum, Deep. And I'm happy that I had the opportunity to hear about this at least in this presentation, Leah, and I'm sure that you will come sometime to further enlighten us about it. We are also in the process of setting up an MOU with Oslomet University. Dr. Alka had come over twice, and we had a lot of interaction, especially in the area of geriatric mental health. So what are the implications of this one-year fellowship course? Let me tell you a little about this course. It is open to those who are qualified with MSc Psychiatric Nursing with medical nursing, and it's a one-year course. There's a stipend fellowship of 25,000 per month, and we have two seats for sponsored students and two for the fellowship candidates. So there is a wide variety of pedagogy. In NIMHANS, we don't believe in just textbook and lecture method. The first rich source of information is from the patient, and that is a very rich source over here at NIMHANS. And apart from that, we also have other, we also follow other pedagogy like problem-based learning and demonstrations, and we also have OSCE here. So people who join this course, I'm sure will be benefited a lot. The implications of this course would be that for the country, we would have a pool of qualified, specialized geriatric mental health nurses who would work to reduce mortality, morbidity amongst older persons. Now, I'm sure you'll all agree with me that India, the land of the Rig Veda, definitely has the utmost respect and regard for its older persons. Older persons' experience is extremely mature and to be valued, and we definitely value our older persons, and that is why this course is so important. Nurses with this qualification can also contribute a lot towards the health of older persons as leaders in Ayushman Bharat Wellbeing Centers in the country, which has started very proactively. And this course would prepare a generation of future teachers, clinicians, researchers in the area of geriatric mental health nursing. So nurses who pass out can work in hospitals and psychiatric hospitals and rehabilitation centers for elderly, long-term care homes. Currently, there are around 730 old age homes in the country. They are now taking semi-skilled personals, but hopefully in future, salary options would increase and there would be opportunities for geriatric mental health nurses to work as leaders in these places. Skilled nursing facilities, assisted living facilities, retirement homes, and community health agencies. So they can also be involved in clinical teaching and work in colleges of nursing. Dual role is being propagated a lot by the Indian Nursing Council and also the nursing division of the Ministry of Health and Family Welfare in the country. And we always look at teaching through clinical work. In the area of research also, there are a lot of scope for these nurses to take part in. So to conclude, as I have told you all earlier, the life expectancy has increased steadily, leading to an increase in the number of older persons. And we all agree that this is a vulnerable group. I think this pandemic has made us realize even more so how vulnerable this group is, and definitely they require specialized care, and mental health nurses are in a better position to provide this specialized care. And I urge all students and teachers who are viewing this presentation to look at the NIMHANS website. We have the NIMHANS prospectus there. You can take a look at the course, the Fellowship in Geriatric Mental Health Nursing course, and you can look at options of joining the course from July 2021. So with this, I would like to conclude my presentation, and I must thank both Alka and Leah. I think you are the best nursing experts whom I managed to get for this webinar today, and I really thank you for sharing your PhD work, Alka, and for sharing the curriculum, Leah, for which you have been very rightly bestowed the Churchill Fellowship Award. I thank Dr. Shivakumar for chairing this presentation. So with this, I will conclude. Thank you.
Thanks, Dr. Salakshmi, for highlighting the importance of geriatric mental health nursing and in terms of training opportunities. So just to add to what Dr. Salakshmi had highlighted, I think the geriatric services at NIMHANS is kind of reaching 2 decades milestone. So it started in 2000, and we have reached 2 decades of services as a formal geriatric clinic and services. But we have had last 3 years, it has been a full-fledged unit. From what it started as a weekly one special clinic, it has now become a full-fledged service where we actually train. We are one of the very few institutes which run DM geriatric psychiatry, super specialization after psychiatry, and subsequently we also have a fellowship in geriatric mental health care, which is for MBBS, the basic doctors. We have 1-year fellowship course, and also we have a fellowship in psychosocial care for elderly, which actually caters to the needs of the psychology and social work trainees, where we provide 1-year fellowship training in geriatric mental health related issues. Even for psychiatrists, we have 1-year fellowship, postdoctoral fellowship for geriatric psychiatry that is there. And NIMHANS being a large tertiary care institute, I think from all mental health professionals, trainees, from psychiatry, psychology, social work, nursing, everybody gets, including neurologists, gets posted to various short-term internships and observerships, and then they get an exposure to the geriatric facility also, many of them. And we have a long way to go. I think apart from the initiatives what Dr. Salakshmi highlighted, we have launched a kind of outreach initiative which attempts to train a lot of lay counselors, which is called as Vayo Manasa Sanjeevani. I think this is something which we are launching on the occasion of Decade of Healthy Aging. We feel a lot of nurses in the old age homes, we can train them to be, we use online training to in lay counseling so that mental health needs can be addressed, wherein dementia will be one of the important focus, because many of them may not even recognize that they have dementia. And another aspect is about, we also are trying to get into home-based geriatric mental health care, at least in Bangalore. This is something which in the COVID pandemic, we had the need of many people 80 and above, they were not able to come to the hospital. So we are actually trying to launch that kind of facility. Once we have the fellowship students, we will be able to actually offer more outreach as a home-based. I think unlike UK, here the home-based mental health evaluations are very, very minimal. And that is something which we would like to develop. And there will be a lot of training opportunities. And we would like to take international exposure in terms of as advisors and as your inputs in terms of developing this course and keeping this curriculum not only focused on Indian needs, as a global need, as to how the trained fellows can actually contribute to the global care and whatever capacities they can do. So with this, I think we have taken a little bit more time, but we have had a very interesting discussions, very interesting presentations. Any questions? So would anybody like to add anything? Any of the panelists, any of the participants, you can chat. If any of you want to ask questions, you can raise hand. And Dr. Salakshmi, I think we can discuss a few minutes if any of the aspects of the presentation needs to be clarified. Maybe we can start and see whether any other questions are there. Would you like to ask anything, Pradeepa?
No, sir. Thank you.
Okay. So I think one reference came about stigma. I think Leah was emphasizing about stigma. I think this is a kind of issue in terms of psychiatry being stigmatized. I just wanted to highlight, I think we have to move away from that notion and say again the boundary between the brain and the mental health is kind of becoming very, very thin. And I think mental health creating stigma in the context of asylums needs to change. Now, mental health and neuroscience are more or less, it's just a question of overlapping kind of domains. So how we define a problem should not actually contribute to stigma. I think this is something we should change. And I agree with you that this is an argument where dementia should lie. But definitely in dementia, the core thing that is affected is the cognition and the behavior. You will have overlap of, you can say, behavioral neurology or cognitive or neuropsychiatry. All these things will have overlap. I think students should understand the mental health field as in the context of neuroscience at this point of time also.
Yeah, thank you, Dr. Shivkumar. Can I just add one thing to that? There is this new concept called brain health that is evolving very rapidly.
Yes.
And again, Scotland has introduced brain health research. I think it's the world's first. So Professor Ritchie from the University of Edinburgh is leading that agenda. And they have set up a national leadership group. And I've just been invited to join that in the last year. So the whole idea of brain health is looking at all the neurological conditions, including dementia, and how do we promote, like we talk about heart health in a preventive way because of the incidence of all the coronary artery problems that we have in populations. Now people are talking about brain health, including prevention of certain mental health illnesses. So yes, I think it's just evolving all the time, and it's interesting to see that the boundaries are all slowly, like COVID has helped all the walls fall off in so many ways. I feel education and research in these specialist areas are also helping all the walls fall off. And we need a more collaborative approach with everyone's expertise, I think, to address some of these issues.
Yes. We have some as to.
Second.
Yeah. Somebody has asked us to how to join the fellowship course. I think Niman's website, Dr. Sailashmi referred. I think prospectus will come out, and the July 2021, we will have an entrance for the July 21 batch. We'll have an entrance exam for this, and as Dr. Sailashmi told, there are 2 seats for the sponsored candidates, which can be from any organizations they can sponsor, or 2 institute fellowship seats are there where it is based on the competitive exams. Will be selected. So for more information, you can reach out to us, the nursing department as well as the psychiatry department jointly runs this course, and we will be happy to share more information.
Can I say something?
Yes.
I think I'm very agree with Leah. And here in Norway also we talk about mental health, say. It's not brain health, but mental health. And education, the knowledge, to our students, to the caregivers, they need to know about what dementia is to minimize the stigma which is related to psychiatric health or psychiatric diseases. It's very important. Like we just cannot neglect it right now. And I think this seminar is so good. And like being an Indian, and I just was so happy to join this and giving me this opportunity to talk about this topic, which is really very important in the coming year. We all are getting older, and we need to prepare it well to combat this problem, and for the caregivers, not only for the patients. And so I would like to contribute the way I can, and I would like to be in touch with you, with Leah also. And in Norway, we have quite advanced nursing programs for the dementia care. So it's already established. So, and I'm glad to know about the Scotland, about how they have integrated this dementia program in the nursing. And we have already some lectures about dementia, but we have other schools specialized for dementia who give the postgraduate dementia care for the nurses students and other students also. Thank you.
I think the COVID has taught us about the benefits of online. I think otherwise we would not have been this comfortable. I think now webinars have become norm, and I think boundaries have become very thin, and we will be able to move beyond the boundaries and connect each other, and then connect having more trainings. I think this is going to be the norm. Not only for the COVID, but also in future. I think this we would be. It's not that we are looking forward to in-person travel, but you need not wait for that to have engagement or to have a conversation. I think the world is becoming much smaller, and we can have access to knowledge and information and sharing our thoughts and discussion. Online is a very, very effective tool for us to do that. Now, Dr. Salakshmi, I think we can conclude the session with vote of thanks. I would request Mrs. Esther Lilly to deliver the formal vote of thanks. And it was really wonderful talks from all three panelists. It was very informative. Thank you one and all. I think Esther would do a formal vote of thanks then to conclude the session.
Good afternoon all. On behalf of NIMHANS, I extend our heartfelt thanks to our chairperson, Dr. P.T. Shivakumar, Professor, Department of Psychiatry, NIMHANS, Bengaluru, for sparing your valuable time with us, sir, for this interactive session. Thank you. I also extend my thanks to Dr. Leah McAdam, Department of Nursing, Midwifery, University of Islands, University Scotland, UK, for sharing your opinion today with us on dementia, the educational nursing program, findings of your survey 2019, then standards of care 10-point national action plan, etc., and to improve the quality of life of dementia patients. Thank you, ma'am. I'm very grateful to Dr. Alkarani Goyal, Assistant Professor, Department of Nursing, Health Promotions, Oslo Metropolitan University, Norway, for an explanation on topic role of nurses in addressing depression and anxiety in people with Alzheimer's disease, focusing on clinical experience, research findings, take-home message. Thank you, ma'am. I mentioned our deep sense of appreciation for Dr. Salakshmi Gandhi, Additional Professor, HOD, Department of Nursing, Bengaluru, for enlightening us with valuable information on scope for geriatric mental health nursing in India, highlighting on focus on lifespan globally, issues of elderly, nurses' responsibility, fellowship in geriatric mental health nursing, and Madam is the continuous support for us and being cornerstone of this webinar. Thank you, ma'am. My special thanks to IT Cell, Mr. Chandan, Mrs. Sindhu, Biomedical Engineering Department, for their unclinching support and coordination. Our heartfelt thanks to all participants. With these warm words and kind message, we move to the end of today's webinar. Thank you, one and all.
I think we have to thank Kriti Deepa also. So she has done a wonderful job of coordinating this event. And all the team, I think the nursing department of nursing team have taken a lot of pains to coordinate all this event.
Actually,
thank you, Ananda.
All because of ma'am only.
Thank you, Ananda.
No, it's all your work.
Thank you, Ananda.
Okay.
Nice.
Thank you. Thank you, Leah. Thank you, Alka. Thank you so much for joining, and I hope that we will meet frequently again online in the virtual world.
Yes.
Thank you so much. Maybe we can have some debriefing afterwards somewhere, or do you have time, or some other?
We can connect separately. I think we can have the live can be stopped.
They're asking for the PPT. I think they have already shared the live streaming Facebook link. If you go there, you can see it anytime.
Maybe I think you can send it by email also to me, so that I will also have a look at it more closely. Live is over now. It is only with us now.
Maybe you can stop recording now, so we can talk freely.
But I can see a lot of other people still there, so I don't know.
Yeah, you can exit the other people.
Can we?
Just wait for a minute.
I can send you a Zoom link to all of you, to Dr. Shivakumar, and so we can meet right now. Is it
Yeah.
is it okay?
That's, yeah, I think that's better maybe.
I'll do
Is
it.
that fine, Dr. Shivakumar, Dr. Leah? Is that fine with both of
Yes,
you?
yeah, absolutely.
Is it
no
okay for you, Leah?
Yes, absolutely. Thank
Okay,
you.
then I'll send you
Shivakumar?
soon.
Is that
Soon
fine?
you will get an email from me.
Okay,
So
great.
just wait whether we can continue this or we should end this discussion. Wait again. So just wait for a minute. He will enable this same thing to continue for a few more minutes. He will exit all the other participants.